Hello and welcome to a myPath Melanoma case study video. I'm Loren Clarke, dermatopathologist and medical director for dermatology at Myriad Genetics. And the purpose of these case study videos is simply to show and discuss some cases that were interesting at both the histopathologic and the molecular level, consider what we might learn from them, and also address some of the questions that sometimes come up about the myPath test and its results. Today's case is a lesion from the abdomen of a 34-year-old male. And the specimen is a deep shave biopsy of skin containing a slightly dome-shaped lesion with a maximum dimension of about 4 millimeters and a centrally located ulcer. So take a moment to study it at scanning magnification, and then I'll highlight a few key features. First, notice that there's no junctional component to this neoplasm. This is representative of the left upper third of the lesion, and here is the right upper third. Now, we can't entirely exclude the possibility that a focal junctional or intraepidermal component has been effaced by the ulcer, but it seems likely that this lesion is at least predominantly dermal. And now notice that with a few rare exceptions, even the larger lesional melanocytes have nuclei that are roughly equal in size or smaller than those of the basal layer keratinocytes, and there is a progressive decrease in their average size from superficial to deep. The field on the left is from the uppermost portion of the lesion, and on the right is an area near the base, shown at equal magnification. So there's at least some degree of maturation with respect to cell size from superficial to deep, although not necessarily a decrease in cell density. And finally, the field on the left is representative of the cell population directly beneath the ulcer, and on the right is a field near the base of the lesion, which presumably would be unaffected by the ulcer and inflammation. Okay, with that admittedly very brief overview, which of the following is the most likely diagnosis? A. Traumatized nevus, B. Combined nevus, C. Nevoid melanoma, D. Deep penetrating nevus, or E. Atypical Spitz tumor. The most likely diagnosis is C. Nevoid melanoma. But if you favored either nevoid melanoma or traumatized nevus in this case, you're in good company. In one of our studies of the myPath test, this case was examined independently by 7 experienced dermatopathologists. 3 of them favored nevoid melanoma, 2 favored a traumatized nevus with reactive atypia, and the remaining 2 said they'd go no further than to classify it as uncertain or indeterminate. Not surprisingly, none of the participants simply dismissed this as an ordinary nevus of no concern whatsoever. All of them indicated that it was worthy of complete excision and further diagnostic workup. The myPath result for this case was a positive 6.7, which is well within the malignant range and indicates that this tumor has the gene expression phenotype of a fully evolved malignant melanoma. It was diagnosed as melanoma by the submitting institution, and a sentinel lymph node biopsy performed shortly thereafter was reportedly negative, but about 3.5 years later, the patient unfortunately developed metastatic melanoma involving multiple axillary lymph nodes. So the histopathologic distinction of nevus from nevoid melanoma predominantly relies on the same criteria we apply to most other melanocytic neoplasms, things like symmetry, circumscription, junctional atypia, etc. But obviously describing a melanoma as nevoid implies that at least some of the features that would ordinarily allow us to easily recognize a lesion as melanoma are either less pronounced or altogether absent. So for example, this lesion is relatively small, symmetrical, and shows some degree of maturation. But according to many of our study participants, the ulcer was the major complicating factor in this case because it made it difficult to determine whether any atypical features should be taken as evidence of malignancy, or whether they might simply represent reactive changes induced by the ulcer and inflammation. And as a result, for most dermatopathologists who examine this case, the diagnosis ultimately depends largely on the detection of mitotic figures within dermal melanocytes, and those were somewhat difficult to find. But in fact, there are 3 dermal mitoses in this section, one really obvious one near the junction, and 2 others that were clustered within a single nest located near the base of the lesion. That mitotic activity must be considered within the context of the cytologic atypia in this lesion, including scattered cells that vary quite a bit in terms of their nuclear size, shape, and chromatin characteristics, a few of which are 3 or even 4 times larger than the lesional cells directly adjacent to them. Now, nuclear pleomorphism is a well-recognized phenomenon in many types of benign melanocytic neoplasms, such as certain types of Spitz nevi and nevi with degenerative or ancient change. But in those settings, the pleomorphism tends to affect a large proportion of the cells. In some sense, we could describe them as homogeneously pleomorphic. This marked variation in nuclear size among isolated cells is very unusual for a nevus in my experience, and also not characteristic of reactive change, which tends to affect all cells within a given area in a much more uniform manner. So the bottom line is that multiple dermal mitoses, especially near the base of a lesion, in conjunction with this heterogeneous cytologic atypia, is a set of findings that should significantly raise our suspicion for diagnosis of malignant melanoma. Now, this case provides an opportunity to address some frequently asked questions about the myPath test, one of which is whether its accuracy in nevoid melanomas is the same as for other types of melanoma. And by all indications, the answer is yes. In one of our clinical validation studies evaluating accuracy of the test by comparison to actual patient outcomes, there were 7 melanomas described as nevoid by multiple dermatopathologists. All 7 were proven to be melanoma because the patients ultimately developed distant metastases. And in all 7 of those cases, the myPath result was strongly positive. And in the clinical setting, we've now tested more than 600 cases considered suspicious for nevoid melanoma. And my experience has been that the test accurately differentiates nevoid melanomas from the entire spectrum of potential mimics, including mitotically active nevi, nevi with degenerative atypia, and nevi with reactive changes. Now, that's not to say that a false negative result can't occur in a nevoid melanoma. It's only to say that there's nothing to suggest that false negatives are more likely among nevoid melanomas, no more so than among any other melanoma subtype. And as I discussed in one of the prior videos, that's largely because the molecular phenotype detected by the myPath test is largely independent of most clinical and morphologic features. Another frequently asked question is whether ulceration or inflammation in a nevus might increase the likelihood of a false positive test result. Now, that obviously didn't occur in this example. This was a melanoma proven by metastases, but it's a reasonable question because some of the myPath signature components do assess inflammatory activity and host immune response pathways. And in our first few years of clinical testing, I did encounter 2 cases with diffuse neutrophilic infiltrates that produced a malignant result, but were favored to be benign histopathologically. Now, we generally avoid sampling areas of a tumor that are ulcerated or contain dense aggregates of neutrophils, and in the years since, we've tested hundreds of inflamed nevi of every possible variety, including dozens of halo nevi, traumatized nevi, and recurrent persistent nevi. And the overwhelming majority generate the negative score we would expect, and in a few cases that did produce unexpected malignant scores, other information later came to light suggesting that they weren't benign nevi after all. So while I wouldn't claim it's impossible, I would say that a false positive result due to inflammation alone is very uncommon. And that's largely because the myPath test weighting algorithm is structured such that it would be very difficult for inflammation in and of itself to produce a malignant result in a wholly benign nevus. Now, false positives can occur, as they can with any test, but they are very uncommon, so I generally advise users that any case that produces a malignant myPath result should be considered with extreme caution. Thanks as always for watching. I hope you found the case interesting and the discussion useful, and if you have questions or comments or want to suggest topics for future videos, please get in touch at lclarke@myriad.com.